All right, we'll go ahead and get started. I'd like to welcome everybody. My name is Krista Sikowski, and I'm one of the clinical leads for CMQCC. To begin, we're going to review some of the meeting logistics. We could advance the slide. Attendees are automatically muted upon entry. Please enter your name and where you work in the chat box at your earliest convenience. After everyone has joined the meeting and we're nearing the Q&A portion, you will receive an invitation to be promoted to panelist. This will allow you to join in with the sound and video for the Q&A and discussion portion of this web meeting. We invite you to turn on your video. Please remain muted until the Q&A portion of the meeting and unmute if you wish to speak at that time. We encourage you to ask your questions live, but if you would prefer to utilize the Q&A box, it is available to you. In a moment, I will be launching a poll. Please assist us by completing it. Next slide. I'd like to draw your attention to additional resources that are available to you. This is the joint CMQCC CPQCC COVID-19 resource site that can be found at www.caperinatalprograms.org. Next slide. ACOG also has a wealth of resources on their site. Following this meeting, you will receive this recording of the session, the slide deck, and all of the links and resources mentioned this evening. Additionally, we'll be sharing resource links in the chat box. Now I'd like to turn the meeting over to Dr. Susan Crow.
Good evening, everyone. I'm Dr. Susan Crow, and I serve as the co-chair for ACOG District 9 Patient Safety Quality Improvement Committee. And on behalf of the CMQCC and ACOG, I'd like to welcome you all to this discussion forum tonight, where we will learn and talk about how to address COVID vaccine hesitancy during pregnancy. We brought this forum together because of the impact that COVID is having on our unvaccinated population. And I'm sure that that's what brings all of you here tonight as well. Our speakers tonight are Dr. Kiran Tammela, and she is Chief of Women's Health at Clinica Sierra Vista. Dr. Kiran Tammela earned her undergraduate degree in public health policy magna cum laude from Princeton University. She was awarded the nationally competitive Harry S. Truman Graduate Scholarship for her work in public service. She was then awarded a full-time tuition merit scholarship to Vanderbilt University School of Medicine as a Justin Potter Scholar. She completed her OBGYN residency at the University of Florida, where she was elected chief resident by her peers. She practiced OBGYN in Florida, New York, and Wisconsin prior to moving to California in 2018. She's currently the Chief of Women's Health at Clinica Sierra Vista at an FQHC serving the needs of California's Central Valley. At CSV, Dr. Tammela has worked to develop a comprehensive women's health program to provide high-quality evidence-based care to underserved women and to build integrated services of behavioral care, dental services, and urogynecology. She's completed the Lean for Leaders program, as well as the Provider Builder certification for EPIC EHR, and she has 2 Bernese Mountain Dogs, an adult son, and a GYN oncologist husband. Second, I'd like to introduce Dr. Han. And Dr. Han is an associate clinical professor at UCLA, Department of Obstetrics and Gynecology, where she's the division director of the fellowship program and fellowship program director of the MFM and associate of the MFM Fellowship Program, and Associate Clinical Professor of Obstetrics and Gynecology. She's an active researcher, educator, and clinician with a focus on prenatal diagnosis of complex fetal anomalies, diabetes, and endocrine disorders in pregnancy, and preconception optimization of maternal health. And she's part of the COVID-19 task force for the Society for Maternal Fetal Medicine. And we're very grateful to Dr. Han for bringing us together. This was something that she recognized the need for, and I want to thank her for that. Lastly, I'd like to introduce Dr. Kavipurapu. Kavipurapu, who is, he practices at Kern Medical Center, and with a diverse background in medicine, law, and public health. His research interests include obstetric and gynecologic emergencies, critical care obstetrics and obstetric trauma, patient care quality protocols for OBGYN, and public policy and legal issues affecting women's health. He earned a Master of Public Health degree from the Keck School of Medicine of USC and a law degree from the University of Laverne College of Law before earning his doctorate of osteopathic medicine degree at Western University of Health Sciences. He completed a residency in OBGYN at Kern Medical Center, which is affiliated with the University of California, Los Angeles. And he is a fellow of the American College of Obstetricians and Gynecologists and served on various ACOG committees and is an article reviewer of the Green Journal. So we're really, really privileged to have all of them here with us tonight. We will start out with Dr. Kiran Tammela. So I'll turn this over to her.
Thank you, Susan. So welcome, everyone. The US has less than 5% of the world's population, but we unfortunately have 14% of all COVID deaths. And the US death toll just last week reached 700,000. So this is obviously not only tragic, but it's also pretty frustrating because this could have been mitigated by better vaccine uptake. So we have millions of Americans that have chosen not to receive a vaccine, even though it's pretty widely available. So our objective with the discussion tonight is to look at COVID vaccine hesitancy specifically in pregnancy and also specific to our region in the Central Valley in California. And we're going to accomplish this by doing a short review of COVID in pregnancy, looking at vaccine data related to safety and efficacy, and to then focus on some patient beliefs and perhaps misperceptions that are contributing to the vaccine hesitancy and look at ways that we can combat that. Next slide. So this slide shows some vaccination data from the California Center for Public Health. And it actually shows absolute numbers of delivered vaccines, not rates, because it doesn't include the denominators of the county population. But there's really good information on this slide. You can see that as a state, we're doing really well. We have a 69% population fully vaccinated rate. And actually 82% of Californians are vaccinated that are eligible, meaning age 12 or older. At least 82% of them have received at least one dose. So only 9 states in the United States are doing better than us statewide. But in the Central Valley, our vaccination rate is really low and our disease rate is still high. So we can see from this slide that Kern County in particular has less than 800,000 total vaccine doses distributed. And that translates so that only 51% of our county's eligible population, again, meaning over age 12, has received the vaccination. Next slide. So as of Monday, there were 247 people hospitalized with COVID in Kern, and 76 of those people are in the ICU. We recently achieved some infamy in Bakersfield nationally when the Washington Post presented an infographic that was pretty widely circulated on social media that called out Bakersfield specifically as the city with the highest hospitalization rate outside of the Deep South, where things are pretty dismal. And this is another infographic that was published nationally. It's from the New York Times, but the data is from Kern County Public Health. And it shows again what we were talking about on the prior slide, that we're at a 42% vaccination rate for the county. Next slide. This slide is interesting, has a lot of good data on it. It shows that 98% of all COVID cases in Kern County have been in unvaccinated people starting with this year, so starting in January of 21, and 98% of hospitalizations have been in unvaccinated patients. So that's pretty persuasive data and pretty good data to keep in mind when you're counseling patients. There's also the interesting part of this slide that shows that 991 people had COVID post-vaccine. And that's important because sometimes vaccine naysayers will point to that and say, well, my mom or my cousin or whoever got the vaccine and still got COVID, so the vaccine doesn't work, I'm not going to get the vaccine. And so that can become a reason for some people not to vaccinate. But if you look at it from a statistical point of view, you can see that that represents such a tiny portion. So 0.27% of vaccinated people tested positive, and probably more importantly, 0.011% of vaccinated people were hospitalized. So again, that 98% of cases unvaccinated and 98% of hospitalizations unvaccinated is important to keep in mind to combat that misperception. Next slide. The next three slides are from the CDC, and they're basically looking at percents of subpopulations of pregnant people that have received vaccinations. So this slide is what percent has received one or more doses of the vaccine during pregnancy. And you can see that the light blue line is all races and ethnicities. You can see that the pink line is the best vaccinated subgroup, and that's the Asian population. The least vaccinated group is the orange line, that's the Black population. And the second to the lowest is the Hispanic population. So you can see that there are certain subgroups that are less well vaccinated. Next slide. And this slide looks at a slightly different statistic, but shows the same trend. This looks at patients that have received vaccination either prior to or during their pregnancy, and looks at those same subgroups. And you can see the same trends there, where the Black population and the Latino population is lower. But overall, even looking at the entire population, the rate is quite low. So the CDC, the most recent data says 31% of pregnant patients nationally are vaccinated. So really our take-home message from this is that the vast majority of pregnant people are unprotected from COVID with vaccination. Next slide. So this next slide does have a little bit of a light at the end of the tunnel that shows kind of the breakdown of the total percent of pregnant patients that were vaccinated, and then it divides that into those that received the vaccination prior to pregnancy and those that received the vaccination during pregnancy. And you can see that the prior to pregnancy bar, which is that light blue bar, is increasing a bit. So we are reaching reproductive age women, and we are starting to see some uptick there, but we still have quite a long way to go. Next slide. So we know that social determinants of health affect care in all aspects of medicine, but there are some reasons that this is particularly true for vaccine uptake. So Black and Indigenous persons have 9 times the rate of death from COVID, and Latinos have 3 times the rate of death from COVID. And we know from the prior slides that these are exactly the same groups that also, unfortunately, are less likely to be vaccinated against COVID-19. So it's kind of that 1-2 punch of social disparity. So what can we do about this? Well, we need to actively encourage our pregnant patients, our lactating patients, patients looking to become pregnant, that they all get vaccinated, but we need to target certain populations to make sure that they're included in our efforts. So what this can mean practically is something that my colleagues are going to talk about a little bit later in this discussion. But I wanted to just highlight something that I was just actually reading yesterday, that our very own district PSQ9 member, Dr. Miriam Navki, just made a comment in the media about a study that was done at Washington University that looked at the strategy of offering vaccination to people immediately postpartum, so still on labor and delivery and prior to discharge. So a lot of these patients maybe wouldn't accept vaccination during pregnancy, but were willing to accept it while still inpatient prior to discharge. And that disproportionately those with comorbidities and those from minority groups were more likely to accept it in that scenario. So that kind of targeted strategy for reaching out for patients may be one of many that we could pursue. Next slide. So if we transition away from kind of talking about the data related to COVID and look more at vaccine hesitancy specifically, we can see that there's lots of root causes of vaccination hesitancy, but they kind of generally fall into 3 buckets: complacency, lack of confidence in the medical field due to misinformation, and that's particularly stuff that shows up on social media, and also lack of convenience. And those are kind of the 3 main reasons why individuals may choose not to get vaccinated. So we're going to talk about each of these 3 in turn. First is complacency. So complacency is a feeling of security, often while unaware of some potential danger. So that fits this situation pretty well. So this is lack of understanding that COVID is dangerous. This is feeling like they're not going to get it. This is not recognizing that COVID is particularly dangerous in pregnancy. So our main way to combat complacency is by presenting specific evidence. Next slide. So first, evidence that COVID harms pregnancy. So this comparator looks at people who are pregnant with COVID versus people who are pregnant without COVID and looks at odds ratios. And they're pretty impressive. So you can see odds ratio for ICU admission, you're 6 times more likely. Odds ratio for death, 15 times more likely. Next slide. And furthermore, if you have COVID during pregnancy, you're actually more likely to suffer with some of those most severe consequences of pregnancy or complications of pregnancy, like preeclampsia and preterm birth. You're 4 times more likely to suffer with that. And gestational diabetes and low birth weight, twice as likely. And this is probably a good place to also mention that the preliminary data is looking like about 1 in 4 women that have COVID during pregnancy are likely to have some sort of long haul or long-term symptoms as well. Next slide. And the final comparator slide is looking at COVID as hurting pregnant people more than non-pregnant people. So the comparator is pregnancy versus non-pregnant. And you can see again, 3 times more likely to be admitted to the ICU and 1.7 times more likely for death. So you see that statistic used a lot actually in the media and on TV, that you're 70% more likely to die of COVID if you're pregnant when you get it. So that's one to kind of keep in mind, and another one that's useful. So a lot of people don't realize that, or a lot of our patients aren't realizing that, and they maybe have some misperceptions about how they're weighing pros and cons. So when they're talking about the pros and cons of the vaccine, or maybe more importantly, like what's the risk of the vaccine versus the risk of not getting the vaccine and potentially getting COVID, it's important to kind of be armed with all of these facts that we were just talking about so that they can use scientific evidence to kind of help them base their decision. So I'll pass the mic now to Dr. Hahn. She's going to take over and talk about some of those next 2 buckets of complacency and convenience and such.
There we go. Okay. Thank you so much, Dr. Tammela. So as she mentioned, our next bucket is about the confidence bucket. Do we have confidence in the vaccine tool that we are trying to promote? So as she discussed, these are the patients who are potentially reading myths and fallacies on social media. So these are the statements that I oftentimes use when I'm talking to patients with this in this bucket. The question that they would have is, well, we don't really know. mRNA vaccines are so new. And as a rebuttal, we would mention that we actually do know a lot about how this vaccine works. And mRNA vaccines have been around since the 1970s. They've just not been mass produced because we've had other modalities for other vaccines. But we've had mRNA vaccines that were for influenza. We've had them for rabies. So this is not a new tool for us. But in terms of how it works for the layperson, I'll briefly discuss that the mRNA is injected into your body. And from there, those little pieces of RNA enter the cell, and the cell takes that information to produce the protein that is necessary for our body to fight off the COVID vaccine. That protein is recognized by the immune system, and therefore your immune system remembers that information so that when it's actually faced with the virus, it's able to combat it. Now that's sort of the general overview. A lot of times I'll go into even more detail about what mRNAs are, because for the lay patient, they don't understand this. And so I'll explain to them that our RNAs are a big class of molecules that are inside our bodies. And in each single one of our cells, there's over 360,000 mRNA molecules. This is just one type and one piece of that mRNA. And all of these mRNAs and RNAs are just blueprints for making proteins. It's very important to let patients know that this mRNA never ever enters the nucleus, and that debunks the fallacy that this is going to change your genetic makeup. I also make sure that they know that this is the only active ingredient in the vaccine and that it's broken down very quickly. I kind of describe it like the secret messages that spies use that self-destruct. These, as soon as they are transcribed within a day or 2, they are out of your system. The next question that patients oftentimes have is, this was such a rushed process. How do we know that it was fully studied? And this is when I will explain to them the vaccine approval process, and that this vaccine went through the same approval process that was just as rigorous as any of our other vaccines, except that we were on a much tighter timeline. And so a way to describe this to patients is that similar to the other world wars that we've had, a lot of times our resources are all diverted towards one cause. And in this case, all the scientific community, the companies, everyone pulled together and put their minds and resources to this. And that's why we were able to recruit patients so quickly and to get this pushed through so quickly. I also tell them that a lot of pregnant women have already had their vaccines. Normalizing vaccines is very important for individuals who think that we might be trying to experiment on them. And so I frequently pull up this VSafe data from CDC, and this was last updated 2 days ago. I looked actually just an hour ago. And it shows that over 160,000 pregnant individuals have gotten their vaccines, and that 5,000 of them are actively tracking. And this is also a good website to point patients who've been vaccinated to ask them to enroll so that they can also be part of the tracked process and to provide information. I also let patients know about some of these mechanisms that are in place nationally. There's multiple vaccine monitoring mechanisms in place, and we are all watching for adverse outcomes. So it's not that we're just turning a blind eye. The vaccine adverse event reporting system has been in place for decades, and this is something that's used for all vaccines. VSafe was especially created just for these vaccines, and Vaccine Safety Data Link is a network of hospitals around the country who, like for example, with the Kaiser systems, are able to pull their data together very quickly, and they all banded together to make this available to the CDC. The next point is that we now, thanks to those 160,000 pregnant women who've gotten theirs, we have the safety data now, and we know that there have been no red flags. And this is where I'll mention the reports on spontaneous abortion after vaccines, and note that the rates are exactly the same as prior to the pandemic. And this is particularly important for those patients who say, well, my cousin got the vaccine and then she had a miscarriage. Unfortunately, miscarriages happen, as we all know, and letting them know that the N of 1 does not equate to a true increased risk is particularly important. I also let patients know that the side effect profile is identical between pregnant and non-pregnant individuals. We don't expect pregnant individuals to have a more severe response, and this has now been proven in this New England Journal paper. So in this graph, what we have here in section B and D are dose 2 of Moderna and Pfizer. And the light blue are the non-pregnant patients, the dark blue are the pregnant patients, and there's no statistical difference between the mild side effects that are seen in the two groups. This is also a good time to mention that I only mentioned the mRNA vaccine because the adenovirus vector vaccine is also available, but these are the two dominant ones in the United States and what's mostly available to our pregnant patients here in California. I also let the patients know that we know that the vaccines do work in pregnancy as they are expected. And so in this somewhat complex graph, what we see here in V0, V1, and V2 are the pre-vaccination, after dose 1, and after dose 2 of the mRNA vaccines. And what you see across the board is that pregnant patients are mounting a response immediately after their first dose, and they mount an even higher response after dose 2. What you see in the bottom right corner is a particularly important graph. And the yellow Christmas tree appearing parts of the graph here on these violin plots are the patients with natural infection. And this is very important to point out that patients who have been vaccinated have a much stronger serologic response, much stronger antibody level compared to those with natural infections. And the analogy that I give for this is that if you are fighting a giant forest fire, which is what COVID in pregnancy sometimes looks like, your body's not going to be able to target those antibodies to just the one protein that makes a difference. With the vaccine, what it allows the body to do is to say, I only want you to recognize this one protein. You don't have to worry about targeting any other part of the COVID virus, because we know that this is the one part that makes a difference. And so this is the argument for patients who want to just try to get the natural infection or report that they've had a natural infection and therefore don't need the vaccine. It's important to let them know that the natural infection does not mount the same response. The next point is that we know that the vaccines work in pregnancy to prevent COVID. And this is a graph that looks at patients after they've been fully vaccinated. And this is why the full vaccination is considered to be at 2 weeks, because you can see at 14 days, that's when the vaccinated group starts to peel off from the matched unvaccinated group. And this is the incidence of COVID after vaccination that we're seeing here on this graph. Now, the next thing I oftentimes talk about is the fact that we know that these antibodies that are being produced by the pregnant individuals are indeed getting to the places we want them to get to. So not only is it protecting the mom, we're getting two for the price of one, essentially. We know that these antibodies are crossing through the placenta and ending up in the umbilical cord blood that has been tested by multiple groups, including ours here. We also know that the antibodies are getting into the breast milk and protecting neonates. And so that's particularly important for patients who are close to delivery, to let them know that getting the vaccine before you deliver is going to potentially protect the baby more than if you wait until you are delivered. Now, this is a slide that we just added in for this iteration of this talk, and that is that pregnant people can get boosters. This statement was just put out by CDC last week. So what they are stating for the pregnant population is that people aged 18 to 49 with underlying medical conditions, including pregnancy or recent pregnancy, may receive Pfizer boosters. Now, the language says may right now because they are not strongly recommending this for pregnant individuals, mostly because we still have so much targeting of the unvaccinated group to do that we don't want to divert all of our vaccinations over to boosters right now. It's more important for us as a whole, as a medical community, to be focusing on the unvaccinated. Now, that said, any patient who wants the booster, I do encourage them to go sign up. Now, these are some practical things to talk about, because we could throw all of this data at the patients. We could talk about all those statements that I just mentioned, but sometimes it just doesn't click. And so oftentimes I like to pull in analogies into my counseling. And I try to cater the analogy to where that patient is coming from. And so, for example, if I have a patient who lives in the beach community, we'll talk about sunscreen and rash guard as being the analogies for a vaccine. When I'm dealing with a student, I'll talk to them about midterm exams. So the vaccine is you studying for the midterm exams and getting ready to prepare for the final exam. We'll talk about seatbelts as an analogy. Yes, it is true that you probably won't get into a car accident, but do any of us drive around without seatbelts? No, because we know that if you were to get into a car accident, you need that seatbelt to protect you. And that's how vaccines work. I'll talk to them about the athlete that's training for an exam or training for a competition. In the same way, the vaccines help your body prepare for that competition. These are two additional graphics that sometimes I'll kind of describe to patients. This one is about herd analogy. And so for those patients who say, I'm healthy, I'm young, I'm not going to get sick, sometimes talking about the community as a whole could potentially get them on board, because by getting yourself vaccinated, you're more likely to be able to protect your grandmother or your sick parent who is right next to you and may not be able to carry their own umbrella. I've actually used this once in a patient, a couple who came in wearing their Star Wars shirts. I talked about it as being sort of like the ex-rebel fighters being trained to target the Death Star. If you have a Death Star coming into your body, you want to make sure that you're prepared for this. So these are all just ideas to come up with. You can cater it to your own population, your own demographic, to see what might help them latch onto the ideas. And lastly, this is just a slide to talk about how important the media could be in our efforts. Because our patients watch the news, they are reading social media. If we're able to leverage any of our patients who are willing to talk, And these are three examples of patients who have ended up extremely ill on ECMO, who fortunately survived. This top one, right one here is one of our own patients who, as soon as she was able to talk after extubation, said, "I wish I had gotten the vaccine." And so leveraging those types of patients to help you talk to the media in whatever capacity will help, because that will help us get the message out. And with that, I'll pass the baton over to Dr. Kavi.
Thanks, Dr. Han. So, I'm going to talk a little bit about the convenience factor, because a lot of our patients tend to come in and say, we don't really have time to get this. I have kids, I have a family, I have, work I have to go to, I'm pregnant, and, I'm already struggling with all of this, or I can't get transportation, or, there aren't any appointments that are available. And these are common things that we tend to hear out in the community, especially when we're practicing, trying to convince patients to get it, because those who have taken the time to go out of their way to get the vaccine have already done so. So there wasn't really much that we had to do in terms of convincing them. But here we, want to also address the fact maybe we can alleviate some of those concerns of convenience, right? Next slide. So a lot of times, we see our patients in prenatal visits. We will oftentimes see them in an antepartum testing unit, NSTs. Obviously, we round on our patients postpartum and in the hospital. But there are other avenues that we can touch base with these patients. And most of the time, when you connect with your colleagues, either the pharmacists or the pediatricians or your lab techs, and giving them that opportunity. I'll give you an example that some of our health systems, especially Kaiser and some of these other systems that are out there, will tend to encourage their providers to partner with each other and say, every visit is otherwise a lost opportunity to counsel your patient, right? And so they'll encourage even, your pediatrician to say, you know what, I know I'm taking care of your baby, but what about you? How are you doing? And then they'll kind of initiate that conversation about the COVID-19 vaccine. Same thing with the pharmacist. The pharmacists interact with our patients all the time. They will distribute the medications. They'll oftentimes do medication consults for patients who are unfamiliar with a certain new medication. And that's a great opportunity for them to also say, you know what, you're here. Why don't we talk about the COVID-19 vaccine? We have it, down the hallway, or we can give it to you. We can set it up for you. So that way they're hearing it constantly from multiple different venues, whether it's your primary care doctor, your OBGYN, your pediatrician, and everybody really around the hospital. And encouraging that type of communication will eventually start setting in with your patients. There are community organizations out there that are trying to partner with the healthcare network in order to help promote the vaccine, whether it's a religious organization or a union, say, for example, firefighters or police officers, and they're oftentimes rallying with us as well. So partnering with them will help. And then the other thing about it is that incentives are often driven to help promote the vaccination. Well, if you get the vaccination, you can enter into this raffle and you can win this X prize, or you can get this gift card. It does take a little bit more of monetary means to accomplish that, but it's something to consider. If you have a really hesitant patient population, there's a certain subset of population that you would like to target. Think about what incentives you can create that would allow your patients to get on board with what you're trying to accomplish. Next slide. So a lot of times, when we start talking to our patients, we want to give them our information. We're in a rush. We try to tell them, I'd like you to do this, and then we can talk about it. But really, you want to open that line of communication. And if they're hesitant in some way, or you're sensing that they may not want to hear you out, then one of the things that I tend to do is just say, it seems like you're a little hesitant right now, but I understand what you're going through. Do you have questions about this? Let's talk about this. Let's kind of alleviate some of the concerns that you might have. And oftentimes patients will start to divulge a little bit about some of the topics that Dr. Han and Dr. Tammela had alluded to, right? They have relatives, they have friends who've had bad experiences, or they hear different conflicting information. Just the other day, I had a patient who is far enough in her pregnancy that she said, you know, I'm starting to realize that a lot of my friends who didn't get the vaccine got sick, and they got really sick. And you know, we're well into the pandemic now, well into the fact that vaccines are available, but I'd like to talk to you about this because I'm concerned. And that in and of itself, we started alleviating a lot of different concerns that she had, a lot of questions that she had. And at the end of it, she said, you know what, I think I want to get the vaccine today. Can we get it? And if they're still hesitant and they're addressing other issues, say, you know, a lot of times our patients are more focused on their medications, their diabetes control, how big their baby is, what gender their baby is. Can I get an off work note because I'm having back pain? And it's really, you have to say, you know what, let's talk about your vaccine status, because just as those things are important, this is also important, and we have to at least address it and start that discussion. And keeping that open line of communication, it may take a few visits for them to do that, but that closing every time you see them will start to get them to think. And they may not be able to give you questions right away, but they'll come back to you at the next visit and then you readdress it with them. And then they may have thought about it a little bit more once they got home. Next slide. We tend to get frustrated. You know, in healthcare, we are busy. We tend to, you know, have our sights set on a goal, our recommendations, our counseling. And then when we start getting resistance, oftentimes we will be a little bit frustrated. And it's really important to take a step back, take a deep breath, and say, you know, we are here to help these patients. Find out where they're coming from. You know, if you start engaging with your patients, oftentimes they will give you a little bit more information as to what their hesitation is and why they feel that way. And then start addressing those concerns, start addressing those fears. Let them give you that information and then run with it. So the other thing is setting a timeline. You know, oftentimes our patients will say, I don't want to necessarily do it at this visit. Let me think about it. So then you say, okay, well, what would you like to talk about it next visit? Or how about we address this the next time we see you in a few weeks? And then that gives you some time. And if you have pamphlets, if you have handouts, any of these resources that we're giving you, have them available so you can hand it out to your patients, especially the ones who want a timeline, and be able to let them think about it, research it, come back to you with questions, and engage in that discussion. Oftentimes, you're not going to be able to convince them completely to do what you would like them to do, but you have to find a middle ground. And that middle ground is really important because it's all about partnering with your patient and shared decision making. And in our field, especially, we do so well with counseling on many other things that this is one of the more important topics that we should also be addressing, just as important as contraception counseling or abnormal bleeding options. And it's okay if you don't get everybody to be on board. Sometimes you're going to have some of those patients who will simply just not be convinced no matter what you say. And that's when you start, you know, giving these statistics and giving them a little bit more information and let them kind of run the show. Because if you tried too hard, then they're going to start losing trust in you as their provider and other things. Next slide. So start sharing, you know, your own experiences. Oftentimes we'll start finding data as we go along. Obviously, we've all been in this pandemic together and we're finding out new information day to day. We're also, you know, getting information from other countries. So a lot of times, you know, I'll start talking about what other countries in Europe or, you know, Southern America are doing because their populations tend to be very similar in size to us. And oftentimes they're succeeding well beyond what we're doing. For example, you know, one of the statistics that surprised me was in Brazil. You know, you have about 35 billion doses that were given of the vaccine, and over 2.7 billion people in that country are already fully vaccinated. Compare that to here in the US, where we have only about 400 million doses that were given, with 186 million that are actually fully vaccinated. And if you compare that to, you know, the states across the country, we're actually doing pretty well in California. We still have a long way to go, but compared to the other states in California, in the country, California is leading the pack with the most amount of vaccines. So if you start kind of posing those numbers and say, look, Other countries are doing this as well. They're experiencing good data. Our state as a whole is still leading the pack. We have ways to go, but this is something that even people in our own community are buying in and getting. That might allow your patients to start getting on board with it. The big thing that I would caution, though, is to avoid playing the politics, because a lot of times our patients don't want to hear that. They're not in the office to get information about which side of the political spectrum we fall on. Rather, they want to hear your own experiences. You know, my patient the other day, my relative the other day, or, you know, one of my former patients had this situation and it worked out for her after she got the vaccine, or something along those lines. And if everything else fails, then the biggest thing that you want to do at least is to promote mitigation of the risk. So promotion of hand washing, social distancing, mandatory mask use. Because even that we are seeing in our communities when the pandemic first started, a lot of our patients and our own community members were really vigilant about this virus and were using masks, hand washing, social distancing, all of the things that we felt would be helping to mitigate the risk of transmission. And those are also starting to fall by the wayside. So we still have to continue to encourage that as well. Next slide. The other thing that we, or at least I'd like to touch on, is community partners and stakeholders, because as I mentioned before, oftentimes we will have patients who want to, you know, hear the story, but they don't necessarily know where to go, and they're a little hesitant because they might have, you know, religious beliefs or other reasons to, you know, cite as to a reason why they don't want to get the vaccine. So in that situation, aside from your own colleagues, whether it's a clinical colleague or whatnot, start partnering with some of the organizations in your community. Religious leaders are a great resource, because oftentimes your patients will go to them for advice and for you know, getting a certain guidance on issues. And if they start partnering with you and allowing you to share that space with them, when they hear it in the office, it's one thing, but then they're hearing it from respected leaders in the community, then they may be a little bit more on board. Same with employers. You know, we live here in the Central Valley with a very high agricultural population. So oftentimes working with those unions, working with the employers, the farm workers union, and as well as, you know, different advisory groups that are in the city. These are all resources for us to utilize in our partnership against this pandemic. And oftentimes the other thing that I've noticed is, like I mentioned before, police officers, firefighters, teachers, you know, we have a huge education community, their union, and trying to get them on board with it and allowing that conversation to happen in that space as well will allow the patients to start getting more exposed to this and get them to think more along the lines that we're thinking. Next slide. So with that, I think I'll leave it back to Dr. Crow.
So thank you all for joining us tonight, and thank you. I feel like I learned a lot from you guys. Chris, I'm not sure if you have any pre-submitted questions, or if Drs. Thor, Franks, and Gabriel Cox, if you can unmute and ask any questions you might have. And if not, I have a few of my own, but I'd like to really give this opportunity to you all. And thanks to Dr. Thor. I know that a lot of people attended this a version of this in the Modesto area, and thanks to Dr. Thor for getting that word out. And so just wondering if you all have any questions, and it looks like we have one more. So if anyone wants to unmute and have a discussion about some of the things that we're facing on the front lines of helping people to understand the importance of getting their vaccine. It looks like we have a lot more people that have accepted the panelists. So
not everybody would accept the panelist link, but I just gave everybody the opportunity to be able to speak if they would like to speak without being seen on camera. Maybe it's been a long day, you know?
Okay, yeah. So if anyone, I don't know if you have the raise hand option from there, if you want to raise your hand, and then we can call on you. to ask your questions.
I think while we're waiting for questions, we could talk a little bit about this fertility myth that we didn't put in the slides. And so I'm sure by now everybody has heard of this concern about infertility as a side effect of the vaccine. And just to give everyone perspective on why that even started in the first place, there is a specific protein in the endometrium that kind of looks like the spike protein. And so even though they are completely distinct structures, completely different proteins, and I think that's where the myth spiraled out of control, is that because there is a similar protein, the non-scientists started raising this concern, and that has been debunked. The American Society of Reproductive Medicine, all of the societies that govern fertility have come out together with a joint statement to say that there is no data at all. And in fact, the infertility world, the REIs, have compared patients who've gotten their vaccine and not gotten their vaccine and shown exactly the same fertility rates.
Thank you.
And one of the things that I was thinking about when we were talking about accessibility of the vaccine is just what we usually do during the flu, right? We go around the hospital. Oftentimes, certain hospitals will offer the flu vaccine to their patients when they're inpatient. And I was thinking more along the lines of doing that for our antenatal testing clinics, you know, walking around with a vaccine cart, you know, a few times a day with the antenatal testing patients who are pregnant, and they're there for 20 minutes waiting on their babies to be reactive. So why not? Let's go around and start vaccinating people. That way you accomplish the 15-minute post-vaccine window all at the same time too.
That's a great idea.
So Dr. Jennifer Franks, looks like you have a question. You've raised your hand. Are you able to unmute, or do you need us to help you with that? Oh, it looks like you got it.
I think I have it. Can you hear me?
Yes.
Okay. The question I had was because I've looked into the process of trying to vaccinate patients on their way out the door when they're admitted for their pregnancies. And the biggest barrier I've come across is the bundled payments that do not include vaccination. And so reimbursement has been this huge issue that we've faced. And I feel like if there was a way to come up with carving vaccines out of that, like, you know, statewide, nationally, anything, that would be that would make a huge difference in this issue, but also with other things like HPV vaccination. And so we could by using this, you could make a huge difference with that. But if anyone has ways that they've managed to successfully get that carved out by whoever their main insurer is for the hospital, I'd really love any advice on that.
That's a fabulous point that I haven't thought through. I can certainly reach out to our hospital administrators and figure out what's happening on the back end and circle back with you on that. Dr. Kavi or Dr. Tammela, do you guys know from your end?
I haven't really seen it play out to the extent that, you know, I think we should play it out to. I'm thinking a little bit about, you know, research projects that I've engaged in fairly recently that have had NIH funding for that, where they, you know, if a participant engages in a certain study, then they get a $50 gift card or a $25 gift card or something along those lines. When I was previously working at Kaiser, I know that they had inherent within their network certain incentives that they did, but because it's all within their system, they successfully were able to do that. But it was also a very limited population that they were able to target. On a global scale, I think it is a little bit more challenging. I don't know if others have thoughts on that, but that is a very interesting point. I think it's worth looking into, and maybe it's something that as healthcare providers, we would have to even lobby for.
Sounds like a task for ACOG.
You're muted, so Susan.
Thank you for bringing that up. You know, we're giving vaccines at our hospital at discharge for people who have delivered, but I do wonder if there's been a choice, and I know it's not an inexpensive process, right? It requires nursing and then observation after, and it's not necessarily an easy process and probably a very expensive one. You mentioned in the chat, Dr. Hun, that there's an incentive program for Medi-Cal. Is that for our Medi-Cal patients?
Yes, it is for Medi-Cal patients. We discovered within our system that it doesn't cover all Medi-Cal HMOs, but it covers some. So for any of you who take care of Medi-Cal Medicaid patients, you can look into this program and see if it's something that your patients might qualify for. But I think it's something like a $50 gift certificate that they can get.
And we've been able to take advantage of that as well for a subset of our managed care payers. So good to look into, and you have to sometimes be proactive to look into it and make sure that the patients receive their incentives. But we've seen some success with that. You know, and regarding Jennifer's question about the payment or the reimbursement or the costs and unbundling from that in the hospital setting, I think it's an interesting point. I mean, working at an FQHC, I am blessed and lucky to have lots of funding and grant resources where happily I don't have to spend a lot of time focusing on that and can spend a little more time focusing on the care. But I think from the hospital's point of view, that's a really interesting question, especially in light of that study we were talking about earlier. So I'm going to approach my own hospital facility and see if I can understand a little bit more about that.
And Dr. Kavipurapu, you may have mentioned this. Are you giving out the vaccine postpartum at Kern Medical Center?
We're not routinely giving it out, but what we have done is set up a on-site vaccine center, both at the outpatient clinic and at the hospital. So patients don't have to necessarily have an appointment. They can walk out of the clinic and just walk down the hallway, really, especially in the outpatient clinic, and just get their vaccine. And I think that has really boosted, or at least helped patients get encouraged, because previously it was a little bit more of an appointment setting and they didn't have time to wait around. I think we can do better though.
On our end, we are vaccinating antepartum, postpartum. We haven't broached the idea of doing it during NSTs, but that's a really good idea. We are still having difficulty getting it into our prenatal visit side just because of the need for the refrigerators. But we do have a site downstairs from our clinic where we send patients. So we're basically trying to make it as easy as possible for the patient to go from saying yes to us to getting that vaccine before somebody else gets to intervene and change their mind.
Are any of the local hospitals, aside from Kern Medical, doing postpartum rounds or antepartum rounds with vaccine carts? Is that something that anybody has heard of? And I think it's an interesting point, at least to try to promote it, because you're, walking around and it's more convenient that the patient's already there.
Yeah, and there's already a system in place for other types of vaccinations, so why not just incorporate that into the workflow? We've managed to get, for example, our patients that are positive for quantiferin are willing to get in. I think it's really worth trying to operationalize that, unless there's cost barriers like Jennifer mentioned.
Ask a question about vaccine boosters, but if anyone locally has a question, we want to prioritize that. But I am in a high vaccination area where many of we certainly, I would think, have probably much higher than 30% of our patients, our pregnant population, vaccinated. Many of them are now asking about boosters, and they'd like boosters. Some of them may have received a non-Pfizer vaccine in their initial vaccination series. And if they did receive a J&J or Moderna, our institution has Pfizer, and that's what's easiest for us to access for our patients. What are your thoughts, or do we have any information about booster recommendations, or certainly booster availability for our patients who are pregnant and received other vaccines?
Yeah, so for J&J, that's a big black hole that we don't really know yet. We're still waiting for their data to find out. And we do know that the initial response to the J&J is low. And so there's a very high likelihood that they will recommend a booster for them. We just don't have that information yet. For the Pfizer versus Moderna question, CDC and ACOG and SMFM, everyone is very careful about saying that so far the recommendations are just for Pfizer to Pfizer. The crossover is not currently recommended. However, I have had patients who are in very high risk situations, whether they work in the ICU or deal with lab specimens. And for those patients, even if they had a Moderna first, I do tell them that you can consider getting it. You just need to be able to find a place that a pharmacist who's willing to give it to you. And so I know some patients have had success, but the official recommendation is currently only for Pfizer right now. We know that Moderna is coming soon, but that's officially, we have to wait for that to come out.
Dr. Han, are you bothered at all by Moderna pursuing EUA for half dose versus full dose? And do you think are you aware of any science behind that, or why it might be?
Yeah,
might pose any risk for cross vaccination?
I think that I wonder if they're half dose, and this is conjecture. This is not any proven science. Moderna did have higher side effects from dose number 2, so I think they're maybe trying to alleviate that. But I don't really know how it's going to pan out, because none of us have that data in our hands to be able to tease out yet. So we're all anxiously waiting for ACIP to give us their recommendations and that data.
We probably have time for one more question if anyone has a final question.
With our last session, we had a really good question about what to do with your colleagues who are vaccine hesitant. So I don't know if any of you guys have well, actually we all do now in California, but what to do about those individuals. And it's just as hard as our patients, with the exception that our colleagues we see on a daily basis. And so I think using those tools and techniques that we talked about, slowly meeting them closer and closer to the middle, as opposed to those patients who are adamant about their beliefs. And if you start having a combative conversation, it's going to go nowhere. So just slowly conversing with them, finding out their barriers, asking them for their literature so that you can get yourself updated on what they're reading. I think those are some potential ideas.
Well, I want to thank all of the physicians today for joining us, and I want to thank all the attendees on behalf of CMQCC and ACOG. You're